Hello, everyone. I'm Rod Hicks, Director of Ethics and Diversity for the Society of Professional Journalists. I will be your moderator for this critical conversation about misinformation and disinformation, convened by the American Psychological Association. Together, with some of the country's leading experts, we will explore causes, consequences, and strategies related to these issues, with a particular focus on building back trust in science and institutions. Before we get started, let's meet our panel. First, we have Dr. Sander van der Linden, Professor of Social Psychology in the Department of Psychology at the University of Cambridge and Director of the Cambridge Social Decision-Making Lab. Also with us today is Dr. Georges Benjamin, Executive Director of the American Public Health Association. From Research America, we have Jenny Luray, Vice President for Strategy and Communications. We also have with us today Dr. Marvia Jones. She's the Director of the Kansas City Health Department and a specialist in violence prevention and community-based health strategies. And please welcome Dr. Chris Voegeli, a behavioral scientist with the U.S. Centers for Disease Control and Prevention. Okay, before we get started, I wanted to remind our audience that you can ask questions or comment live via the YouTube chat below the screen. Our panelists have made themselves available to extend this important conversation to our viewers. You will hear the terms misinformation and disinformation several times throughout this conversation. The difference is that misinformation is just something that's incorrect. But disinformation is something that is intentionally deceptive. Just want to make sure you understand that distinction when you hear these terms. Now, the harms of misinformation and disinformation cannot be understated. They exacerbate some of the most serious issues we face as a civilization and impact so many aspects of our society. Public health is one, the economy, education, elections, government, and civility. The first thing that I want to ask here is, how did we get to this point? How is it that people are choosing to believe information other than what is evidence-based? How are we here? How are people not believing what they hear from scientists and other institutions? Chris, you want to start us off?
Yeah, thank you, Rod. I think a good place to start with this is talking about the general decline in trust in government. When it comes to trust in government, Pew Research has reported really a decades-long decline since the Johnson administration, with peaks and lows associated with very specific events like the 1979 oil crisis, the government shutdown during the Clinton administration for low points, while 9/11 stands out because trust in government spiked to a point that had not been that high since Nixon was in office, and it's never returned to that peak. However, looking at just the highs and lows might lead us to believe that very specific events are causing a decline of trust in government. But it was on the decline long before the 79 oil crisis. So what's going on? Pew makes a compelling case that trust in government is tied to people's perceptions of government fairness and satisfaction with the state of the country, as those trend lines really seem to overlap fairly well with the decline in trust. However, I would add one more piece to this puzzle. Since the early 1970s, when people started tracking interpersonal trust, we've seen a steady decline in that as well. It seems that on average, people are less likely to say that most people can be trusted, and there's a good amount of evidence that interpersonal trust correlates with organizational trust. However, once again, we're left with the same question. What caused the decline in interpersonal trust or organizational trust? I really believe the answer, at least in part, is access to information. As trust declined through the decades, it coincided with the increase in percentage of U.S. households with a TV or telephone. So, not only could people be given reasons to not trust other people or the government on TV, but they could also spread those stories and their own stories by just picking up the phone. These stories, true and false, were probably just as evocative and memorable as COVID misinformation is today. And as someone hears these examples, they fill their semantic network, their working memory, and the examples probably start to change how they see the world. Stories of government taking advantage of you are probably easier to believe if you can quickly draw from a plethora of stories of people taking advantage of others or when the government lets you down.
Dr. Benjamin, do you have thoughts on this?
I think that Chris's points are all well taken about this. This is a complex problem. And one of the things that we certainly know is that we really don't have really good risk communication. And people don't have really good science literacy. So, for example, people don't really understand the scientific process. They think that someone does a research study, and the results come out, and that is exactly the way it is. Well, it's part of a hypothesis, and people need to get a better understanding of what the actual scientific process is. And that process is iterative over time. Someone sees an observation, they make a hypothesis about what that observation means. Someone then studies it and either proves it or disproves it, sometimes partially proving it or partially disproving it. And then the cycle repeats itself by being either studied by someone else, or someone else took another angle at it and comes out with a result. And then over time, you get what we call, by that process, something called facts. And those facts are backed up by the observations, and the scientific process. But the average person doesn't really understand that complexity. And certainly most of us don't think of the world that way. We see the sun come up in the morning, so it's morning. And so our frame of reference is very important in this prospect. When I initially started practicing medicine, I started at a time when, quite frankly, we health professionals had all the books and people did not have access to the information. Those books were a couple $100 a text. Most people wouldn't buy the book, and most people wouldn't read it cover to cover. So what I told my patients was the facts. They either had to believe it because they had a trust in me, or they didn't believe it because they did not have a trust in me. But if I had that physician-patient relationship, they were likely to trust it. Now, patients, can get the book online, and of course they can use what we call Dr. Google, meaning they can use the internet to get a whole range of pieces of information. And in that line, that creates the opportunity, when you have good information, for that good information to get to people, and when you have bad information, for that information to flourish.
I see Jenny nodding. Did you want to add to this discussion, Jenny?
Couple things. One, there have always been pockets of mistrust in science. The anti-vax movement long precedes COVID, and water fluoridation in the 40s and 50s. I'm sure, Chris is nodding his head, and so is George's. That was weaponized. That was used by the strident anti-commies, saying that, this was a plot that Russia was, purporting against the US. So this is not the first time that, public health information has been purposely misconstrued. But I think the points that Dr. Benjamin and Dr. Voegeli have made in terms of how quickly that information gets dispersed, that's the major difference. And then the other point I wanted to make is that scientists are still among the most heavily trusted professions in the US, and in fact, trusted twice as much as elected officials. So while trusted government is a huge factor, particularly when the information is coming out from a government source, I think it's also helpful to look at the way scientists are viewed by the public separately, and also the trends there as well, which are not positive.
I'm really glad to hear that. As you guys know, I'm a journalist, and trust in the news media is pretty low, which is really unfortunate, given that what people don't seem to understand is that what we're publishing and broadcasting is not just something that we made up. We go and we talk to experts, and it's based on evidence, what we report, but it's still not connecting to people. I want to hear from Dr. Jones on this, but if anyone else wants to address it, I'm happy to hear from you as well. Dr. Jones, what are the major impacts of misinformation and disinformation on local communities based on your experience in Kansas City?
Yes, Rod, it's incredibly undermining, and it undercuts so much of our work. It also undercuts any types of relationships that we might have with the community. Obviously, disinformation and misinformation spreads more diffusely and more easily than any of our formal communications as a local government agency. And so there is definitely an upper hand in being able to get their own talking points out, that kind of erodes the trust that we have with our community.
What are some of the what's the impact of all of this? What are some of the major impacts of misinformation, disinformation on, let's say, local communities? Dr. Benjamin, can you address that?
Sure. I mean, well, let's start with COVID. Conceptually, people should have been trusted messengers, political leaders, that have resulted in the wrong information getting to people. And because of that, that has resulted in poor health outcomes. But it's not just that COVID. We had this whole issue around health insurance coverage. When we had communities that have opposed the expansion of the Affordable Care Act as an example, and putting out misinformation by public officials about what those that coverage would do. You may remember the efforts to say that many of the Affordable Care Act would result in death panels against seniors, which of course was absolutely not true. But things like that happen a lot, and I think, as Jenny pointed out, there's been, in some cases, purposeful misinformation, and we're seeing that right now in a couple of our states in this country where leaders are doing this. By the way, it's not just political leaders. It's people with a very, very loud megaphone. So there's a group of 12 people that we call the Disinformation Dozen, for example, that have been actively undermining the efforts of vaccines. And the problem you have is a small number of people in today's environment can create an enormous amount of disinformation because they can target it through the numerous communications channels that we have today.
What barriers do leaders face in combating misinformation and disinformation?
Yeah, it's really difficult. When you're a part of a organization like a city government agency or public health agency, your relationships with the community that you serve are everything. However, we also have sort of formalized processes for responding to messages that are untrue or misleading. It might take me a day or so or several hours to get the messaging approved and put out on our outlets. Whereas these folks can compile and publish messaging in a matter of seconds and minutes. And so it does cause us to have to work that much harder to maintain the trust of our communities. And unfortunately, who really pays the price for that are the communities who would really benefit from the things that we're asking them to do or recommending to them to do. But because they're getting so many different messages, disinformation, misinformation, they don't know what to do. So some people decide to just do nothing.
Well, we have people who are deliberately spreading misinformation about health-related issues or how to take care of yourself. What is motivating that? Jenny, can you give me an insight on that?
To what George has said, that part of it is a political agenda. Part of it is an anti-establishment agenda. So it may not be a partisan agenda, but it's that agenda of just wanting to destabilize trust in government. But I'm going to turn it over to one of our psychologists.
Okay. So, Dr. Van der Linden, can you address that?
Well, I think there's a difference between why, regular people share misinformation, both intentionally and unintentionally, and those who are purposefully sharing misinformation with the intent to deceive or harm other people, or what you referred to earlier as disinformation. I think it's pretty well established that disinformation is mostly a function of A, politics, and B, monetary incentives. And so I think that was mentioned before. I mean, either people are making a profit off of it, and that's classically been the case with not people who are duped by conspiracy theories, but the people who concoct and spread them. They generate whole platforms and make a business off of selling conspiracy theories, or people are politically motivated. But I think when you talk about regular people who are sharing misinformation, they might do so for reasons other than politics, or that they're certainly not making money off of it. So I think that's maybe a useful distinction to introduce. Because generally, one of the questions that came up earlier is that of the infodemic, right? People are bombarded with information, both true and false, and it's harder for people to sift through and figure out what's accurate and what's not. So some of the misinformation that people share might be unintentional. Some of it might be because they're motivated by spiritual, political, religious, or other social motivations that people might have. Some of it is accidental, right? And some of it might be because people actually believe it, and they think that they're sharing accurate information while in fact they're sharing misinformation. So I think there are a lot of different motives there to potentially unpack.
Can someone discuss how the 24/7 news cycle, news aggregators, and social media have presented some political leaders with the opportunity to spread misinformation for their own personal advancement?
Well, I think several things have changed over the last 50 years. Number one, when we had regulations over the official news channels, and you had to basically have the old Fairness Act, where you had to present both sides of an argument. You got both sides of the argument, and you also had fewer opportunities for people to relate that to the public. So you got both sides of the argument twice a day. With the explosion of cable TV, you get now 24/7 bits of information. It's always breaking news, so it's designed to get whoever cuts on the tube at the time to see it as something new. But there's also a great confusion now between solid journalism that is giving you the news and the facts versus commentators who are, giving you information through their ideological lens. You couple that with the fact that, quite frankly, we now all kind of live in our tribes. We listen to, watch to people whose views and political ideologies align with ours. And we often fail to listen to both sides of that ideology. And so, quite frankly, 24 hours a day, 7 days a week, you can hear something that reinforces your predetermined biases and beliefs. And then once you do that, those reinforced ideas become, in your mind, fact, whether they're facts or not.
Thanks for that, Dr. Benjamin. I want to just try to expand this to historical distrust in institutions. There's no doubt that some people of color have lost trust in the healthcare system. They don't trust vaccines, and some feel that they've been discriminated against. So how has misinformation, disinformation exacerbated these biases, discrimination, and racism?
Right, Rod. And so we know that the level of trust that many people of color have already had with these types of institutions, such as public health agencies or local government or whomever, we know that they are already coming from a place of mistrust in many cases.
Right.
And so when there is this disinformation out there, it's very easy for someone in that group to say, okay, well, this makes sense. This validates what I already thought about these institutions. And so I'm more open to it, even if it sounds outlandish. Because of my perceived history with these institutions, I'm at least open to the idea of entertaining these strange theories or strange myths that may cause me to act against my own best interests.
Dr. Jones, are there any examples out of Kansas City of the consequences of misinformation and disinformation that you can share with us?
Yes, unfortunately, there are too many. But the one that I think hit hardest for me and I took sort of personally was there became a contingent of people in the African American community here who said that I don't want to get my shot. I don't want to get my COVID vaccine at the Kansas City, Missouri Health Department. And I don't want to get it in any of the local pharmacies that are in the urban core of the city. I want to go to the suburbs to get mine. I say, why would you do that? Gas wasn't quite as high then as it is now, but still, why would you want to do that? And the response was because I believe that if it's targeted to poor people or to where the urban population of Black Americans is, I'm going to get a subpar product. I'm going to get the tainted or the vaccine that's, going to do something negative to me. But I know if I go out there where there is a higher population of white people, then I will be able to get the right product because I know they'll protect them. And so there are all these questions around who is the they, and we've done all we could just to get the vaccine from the state. We don't have the time or the energy to be partitioning, who gets what else, so trying to reason through them. And the rationale we were able to give was, look, everybody is going wherever they can get it at this point. There is no separate, vaccine for people of color versus white people or what have you. But just that type of thinking, and I'm the type of person who takes things like that personally. It's like, you think I would be working around an operation that would do that? But that was just a very sad moment.
But you understand why somebody would feel that way, right? Given what's happened in this country over there.
Sadly, I do. I do. And what was frequently brought up was, this sounds like Tuskegee all over again. And then I tried to sort of deftly remind people that, well, the Tuskegee thing, they were withholding something that they knew would help. Yes, there was some deceit in that process where people thought they were receiving something good, but the main takeaway from that was people were withholding. Once we knew penicillin would have treated the syphilis, they weren't giving it to those guys who should have received it. Here we are promoting, people of all races and all hues are saying, here, let's take this to protect yourself. And I tried to point out the differences, but yes, your point is well made that there is a background for a lot of this.
Professor van der Linden, can you address?
Yeah, so if you look at the kind of fingerprints of misinformation, you see that, across lots of different examples, one of the things that it tries to do is play into people's pre-existing biases to try to get traction. Sometimes it's engineered that way, sometimes it just organically happens, and that's known for a long time. If you look at studies of the effectiveness of propaganda during World War II, one of the things you find is that in those areas of Germany that showed prior support for anti-Semitic policies, that's where the propaganda was most effective. Obviously, it was also effective on people who showed no prior support for anti-Semitism, but it got most initial traction amongst those voters who are already harboring feelings of racial and resentment of other forms. And I think that's still true today. It's just massively amplified on social media. Instead of just doing a mass sort of marketing campaign, you can now micro-target people based on their features. It used to be the case you can go on Facebook and sell ads to people who have liked pages that hate Jews or African Americans. You can find any sort of instance on these platforms. I mean, that's been removed by now, but it was possible to target communities that carry a significant amount of hatred to other groups of society and bombard them with information that reinforces those existing biases. And I think that's one of the most dangerous aspects of misinformation, actually, that it's able to tap into a lot of the, people say, what's so different now? I think what's different now is our ability to really synthesize and deliver misinformation in a way that actually amplifies some of the worst things about the human condition.
Well, social media is still playing a role, right? Jenny, can you speak to the role that social media continues to play in misinformation and disinformation?
Well, I mean, it's enormous. A lot of people are studying it. It's gigantic. Prior to COVID, when people started looking at the impact of social media on the anti-vax movement, for example, there was an increase in families refusing to vaccinate their children against measles, mumps, and rubella. And when they looked, when they studied where the anti-vaxxers were on the web, they were everywhere. They had buried into PTA groups. They had found spaces all throughout the internet when you mapped it. When you looked at those who were pro-vax, they were occupying a much smaller real estate. So that study in particular always struck with me. But, I think it's safe to say that the impact is enormous, and we do need to pursue policies from, the top down, but we also need to build confidence in scientists and public health information from the ground up so that people will become more immune to that misinformation. And there are a number of studies that show how do you build that immunity, among people so that they become more questioning of information that they receive.
Dr. Benjamin?
Yeah, and let me add, one of the ways that people who are purposely trying to create disinformation is to create distrust in everybody. So we have state-sponsored groups whose goal is they go into the say for a pro-vaccine community, and create anti-vaccine materials. Then they go in the anti-vaccine community and give a reverse message for them. But their ultimate goal is to create distrust. And we've seen that for vaccines. We've seen that against abortion. We've seen that against guns. We've seen that in health insurance coverage. But their ultimate goal is not to promote one ideology over the other. Their ultimate goal is to create distrust and confusion and fundamentally undermine the democratic process. By the way, some of those groups did use the evidence. They do this in a scientific manner. They use that evidence, and then they use that to undermine the political process for voting and messages for political figures, because their ultimate goal is a political one.
There's a lot of misinformation, disinformation about a lot of different topics and disciplines. But when it comes to health and science, we're often talking about life and death. So why are people susceptible to misinformation, disinformation about health and science? It seems to me that would be, you would want accurate information because of these life and death issues.
The big thing about medicine and health is that it's there's an art to medicine and there's a science to medicine. And people often get confused about the two. Every patient is different. Every therapy for that patient needs to be individualized. And so the opportunity for misinformation, because one person had a different health experience than another, even with the same therapy, creates the opportunity for misinformation. And then, we're in a rapidly evolving scientific environment. So for example, these COVID vaccines that we had are a technology that's actually been around for many years, but we're just now beginning to use it. But the good news is the public observed that science in real time. We came out with a very safe and effective vaccine, but the communication about the scientific process did not mirror the incredible science that was done to create the vaccines. In other words, we did not communicate it well to the public about what we were doing. In fact, we made the assumption that people knew what a vaccine was.
Yeah, I agree.
So things like that.
Yeah. Jenny?
Yeah, sure. I think it's really important to look at the sort of bifurcation in our society between those who practice science and those who don't. So the scientific community and the non-scientific community. And there's a lot of work right now being done, mainly at the grassroots level, to really create more engagement between scientists and non-scientists. Rod, you asked, well, why did folks believe information that wasn't true? And just telling them what is fact is not going to help. In fact, that's called the deficit model of communication, which scientists have practiced for a long time, seeing the non-scientists as kind of empty vessels. And if you just give them the right facts, they're going to, come along. And we've learned that doesn't work. You need to create a dialogue. People have concerns, and you need to listen to those concerns. Pediatricians who have been most successful in convincing families who were maybe vaccine hesitant to give their kids vaccines have used that approach. There's a whole movement going on right now across the United States where scientists of across disciplines are reaching out at the community level and trying to help build those bridges. And I think that, along with improving, K through 12 science education, which George has mentioned, so people learn the hypothesis testing and the scientific method. I think those two forces together could be very helpful.
Chris, did you want to say anything on this?
Yeah, I would add in one piece to this is that, sometimes by accepting misinformation, it makes you feel better. It makes you feel more comfortable that there's this risk management that's done. If I believe misinformation that discounts the severity of COVID, then I don't have to be as concerned about it. And I think we've seen this for a long time. The classic example I feel is the instances of people discounting the impact of smoking. They would throw out examples like that my grandma lived to 92 and smoked every day and she was fine, to discount the harms that would be leveled against them from smoking. But I would also say sometimes misinformation provides hope, that if there isn't a treatment out there or the treatments aren't effective, a miracle cure instills hope in people. And that's another one we've seen, especially in the field of cancer diagnosis and treatment. But that, if your outlook isn't that great from the regular treatments, then believing some miracle cure, some natural remedy is going to save your life, at least helps you in the short term.
Well, thanks for all the contributions that you guys have made to this discussion so far. What we want to do now is get into some strategies for addressing these issues. But before I do that, I do want to remind our audience again that our panelists are here live in the chat below, and please share your comments and questions, and we'll do our best to address them. So let's talk about some approaches to building back trust and curbing misinformation and disinformation. What psychological science-specific solutions are there to address misinformation and disinformation? Dr. van der Linden?
Sure. So, at the very broadest level, I think we can distinguish between proactive versus reactive approaches. So the most common approach is to debunk and fact check. And that's not a bad thing. I mean, I think fact checking is a good thing, but there are some limitations to the approach of debunking misinformation after it's already spread and people have been exposed to it. One of the primary psychological mechanisms that is of interest here is what we call the continued influence of misinformation. So what we typically find is that once people have been exposed to misinformation and they acknowledge that they've seen a correction, they've seen a debunk of some sort, they continue to rely and retrieve details from memory that are based on the initial misinformation. And so once you're exposed to misinformation, it integrates into your memory networks, it makes friends with other things that and it becomes very difficult to then undo. As they say in legal terms often, you can't unring a bell, right? Once the jury is exposed to some media footage that they weren't supposed to see about a defendant, and the judge says, now disregard that, that's almost impossible to do. And it works the same way with misinformation. And so a lot of research have been pivoting towards more proactive approaches, such as pre-bunking or psychological inoculation. And the idea here is simply to help prepare the mind for the types of manipulation techniques that it might encounter, specifically using the vaccination analogy. So you expose people to weakened doses of the types of attacks that they might encounter online based on misinformation, as well as ways on how to refute them by identifying either why it's false or the underlying technique that's being used to dupe people, whether it's the use of a fake expert or a conspiracy theory, you name it. And through that process, people can build up cognitive antibodies or resilience. And the idea here is really that instead of just giving people more facts, what you want to do is give people a weakened simulation of the types of misinformation that they might encounter so that they can build up resilience beforehand, so that once they encounter it in the wild, it's been neutralized in the the antibodies and the T cells are prepared to fight off the misinformation. And that's kind of what we're exploring now as a more proactive management strategy.
It sounds sensible, but the thing that I'm thinking is, how do you scale that to get that pre-inoculation to everybody who needs it, everybody who is susceptible to disinformation and misinformation? There may not be an answer to that, but that was the thought that I have. And I'm glad to know that there is somebody like you guys working on a solution.
Yeah, I could quickly try to answer that. I mean, it's a great question. I mean, the question of scalability is very important. There is clearly issues with certain types of take up, right? The people who sign up to want to learn more about this or to identify the strategies beforehand are the ones that are kind of open-minded in the first place. So one of the ways that you could do this, and we've explored some collaborations with social media companies who control most of the flow of information, is to actually, have them implement some of these strategies. So an example could be on YouTube, where in the ad space, that annoying ad that you get to see before you have to watch a video. Instead of having an annoying ad, they could actually use that space to prepare people for the types of misinformation that they might see on YouTube from time to time. And whether or not that misinformation actually comes isn't that important. It's just important that people are prepared and that they could take useful steps to do that. And the way to scale it is actually they could force that ad on every single YouTube user, which are billions of users. Now, I'm not saying that they're doing this, but it would certainly, I think, be helpful in terms of trying to scale it. We've done some initiatives with the World Health Organization and the United Nations to try to, for example, gamify this approach and have it go viral on social media so people are more likely to engage with it. But at the end of the day, I think the challenge remains that those who need it the most might be the most unwilling to expose themselves to this type of content. So I think it's a useful question to explore.
Sure. So, Jenny, you have thoughts on this?
Well, that social media approach is fascinating. On a broader societal level, we know from polling that people who are more familiar with medical research are more likely to trust it. And that's true across, by ethnic and racial groups as well. So just having that, something being familiar to you, is helps to engender trust. And so I think we need to keep that in mind when we're talking about, how do we close the gaps between the scientific community and the non-scientific community.
Well, Chris, you want to speak to that?
Well, very briefly that, as Sandra was talking about building resilience, one thing we continue to make the case for is the need for science, government, the healthcare industry to also think about building and maintaining trust as a way of building resilience to misinformation. Additionally, somewhere that psychology has a lot of influence is the particular interventions, especially those that are focused on building metacognitive skills, teaching people how to think about how they think, which is at the core of a lot of these literacy interventions to address misinformation, information, digital health, and media literacy. So that continues to be an opportunity, even if scalability is a question going forward.
And Dr. Benjamin, did you want to add?
Yeah, I think Chris has got it right on point. And that means, first of all, we who are communicating to the public on a regular basis have to do that with intention to build trust. That means that when you're communicating, you decide what's a really important activity you want to give people. You tell them what you know, tell them what you don't know, tell them what you're going to get back to them. Do it on a regular basis so that they see you in the media as a trusted messenger. We also have to build a cadre of other trusted messengers, particularly in low-income communities, particularly minority communities. One of the things that we learned very early on in the HIV/AIDS epidemic was that we had to build a cadre of people who were trusted in those communities. So we educated barbers and beauticians community outreach workers to go in those communities, because those communities would only listen to people who were in the hood each and every day. We've now seen that in COVID. And so there's been an effort, of course, to do a better job of educating community leaders, faith leaders, local individuals who have, street creds in the community. Give them the right information, because they're subject to misinformation and getting the wrong information as well, and spreading that misinformation. But if given the right information, they're much more likely to, once they understand it and it's been shared with them, they're much more likely to undermine misinformation when they hear it and cut it off at the source. Everybody who's grown up in a community knows the lady or the little old man down the street who knows everybody's business and shares everybody's business. They know the person who is in the community, going door to door, because they're selling things, they're engaged in their church, they're engaged in public events, and having those people have the right information is, I think, the key to helping rebuild community trust. But it has to happen with intention. It doesn't happen just normally.
Let's talk specifically about people of color and communities of color. Many people from these communities feel that they've been discriminated against within the healthcare system. Some might reference back to the Tuskegee study. So there is some particular distrust among some communities of color. What can be done to address that distrust specifically in those communities?
Yeah, let me start by just saying we've got to deal with the structural racism that we have today. It still exists. We have still people who deny that racism exists today. That structural racism is with us today. There are people that are afraid to use the word racism because they think the world's going to come to an end if they use the word. The truth is, it's not. And I think we've got to do a lot to recognize that people are still being treated in a desperate manner. And while we talk often about the historical stuff, Henrietta Lacks, the Tuskegee study and things like that, the truth of the matter is most of our folks know the words, in communities of color, but they may not really understand what actually happened. But they're reacting mostly, that's a historical thing they have in the back of their head, but they're reacting to the way they were treated this morning, yesterday. So if you went into a healthcare system and you were disrespected when you went in, you're not going to trust them when they want to, provide you with some, advice on your medical care. You're going to go in with a distrusting attitude because of the way you've been treated the last time you were there. So I think one of the first things we all need to do is think about how we're treating people today. Recognize that we have systems of structural inequities, dismantle them, and that will go a long way, I think, to begin reestablishing that trust in community.
Jenny?
George just hit the nail on the head. I mean, look at maternal mortality rates among women of color. There you can point to a lot of disparities now and outcomes. So I think that's what us white folks have to keep in mind. This is not just about getting over history, right? This is about the present day.
Well, are there some specific solutions based on research and experience specifically for communities of color, Dr. Benjamin?
Yeah, well, let's start with doing a better job of educating our medical providers. We still have physicians that don't look like me, who think that African Americans feel less pain than whites, that our skin is thicker than whites. By the way, these folks had a class in anatomy, so they know that that's not true, but that's a bias that they come there. That still feel that the reason that a person of color was non-compliant, that's the magic word that they use, in their medical care was because of neglect on their part not recognizing that, yeah, they didn't take the medication because they couldn't afford the medication. They couldn't afford the medication because they had a low income job. And you prescribed a medication that was unaffordable to them. So we've got to do, we got to own this as our piece of this as health providers to start with. I think the other thing we have to do is recognize that our society continues to be structured, in ways that are inadequate and unequal. 80% of what makes you healthy occurs outside the doctor's office. For an ER doc, that's a very painful admission to make, but it's true. And I remember when my dad died. I tell this story a lot, and like many folks, I was involved with helping my mom go through that process, and so I got a chance to look at some of the family papers. And one of those papers I looked at was the deed to our house. Now, our house had long been paid off, but we still, of course, had a paper title. And on the back of it was a stamp which said this home could not be sold to African Americans. I'm paraphrasing what it actually said, but the fact was that was a rude awakening for me, that I was living in a home that we had purchased through my, adolescence to adulthood, that at one point in the city of Chicago was redlined, and folks of color couldn't have bought my house. So I always talk about that as an obvious example of that. And we now know that we still have situations where people of color are charged more to get a loan, where they're denied loans at a higher rate. We know that African Americans are pushed out of medical school faster and less are brought into medical school. So we still have a long way to go and a lot of barriers that we have to get equality in our society. And that's the African American part of that story. Our Latino neighbors and colleagues have similar stories. In some parts of this country, our Asian colleagues have similar stories. And so we have to deal with stigma, racism, discrimination in all of its forms. And that is really the root cause of a lot of issues where people are now angry because they felt they have been disrespected, distrusted, and it creates lack of trust in a variety of settings.
Yes, what we have really learned throughout this COVID-19 pandemic time period is that we have to work even harder to maintain our relationships in the community, particularly with marginalized groups such as people of color of multiple varieties in our communities. We have to be working overdrive, even in so-called peace times, to be building those relationships. We have to be there when they want to know what their kids can do over the summer, what types of summer camps are available. Let us provide a service for you. Let us connect you to those. They want to know where to find food resources. If there may be food insecure, we're there for that. So that when it comes time for us to give some actual recommendations that we need folks to follow for not only their own health, but the health of our community, they are then more willing to listen and to be more receptive because there is that existing relationship. They have more reasons to trust us at that point versus they haven't really heard much of us or much from us in those other intervening time periods. But then we sort of take on this sort of outsized role in the moment of crisis, and that can sometimes raise people's suspicions. So we have really leaned into this idea of maintaining year-round, even in peace times, connections to our communities.
Is there a role that community leaders can play in assisting in communities of color to help address the
Well, let me start
distrust
and
there?
let me turn it over to Jenny. Obviously, we've got to do a better job of teaching risk communication. We've got to do a much better job, communicating overall. We need to make sure that the media gets the right communicators in those venues. We've got to get better at using social media. We're not as good at using social media as our kids are. I guess the next generation will be better because they're more facile with social media than folks of my age. But the truth of the matter is, policy at the highest level of our government was being determined and communicated through Twitter. If that's going to happen, then we in the health community are going to have to become very good at rapid response, using that 190 characters, 180 characters, whatever it is, to communicate. And so we're going to have to be, the elevator speech, the short comment, we're going to have to get much better at it.
Jenny.
Yeah. I mean, the
Go ahead.
public wants to hear more from scientists and public health officials. In our survey work, it is among the most bipartisan answers, virtually no difference among political affiliation in those who believe that it's the job of scientists to communicate their research to the public. So that's critical. And back to what George has said in terms of communication techniques, people can tell when they're being patronized. They can tell in a split second. And I think, there has been a sort of a paternalistic type of communication that, people like George's and Ashish Jha and others are really working hard to, get away from. And there's a lot of training going on for public health officials, for scientists, to how to communicate in a more respectful, effective, more of a dialogue rather than, we're just going to fill you up with information. And if you don't believe us, then, there's something wrong with you.
Do any of these solutions sound like they would work in towns and cities?
Yes, I believe that this will start with really supporting science, technology, engineering, all of those types of concepts, supporting those types of strategies that promote that for people, even in the elementary, middle, high school level. We have to get back to that. We have to place an emphasis on teaching core concepts about personal health and well-being. I know that in many districts, folks have cut those types of programming. It used to be when a lot of us were coming up, you would take health class in gym. And for a lot of districts, this has been turned into, more academic time. And so we really need to promote those things where we can. And as a health community or as a local leadership community, we should also be promoting those things. We should also be making sure that any information we provide to the public is in a digestible format. And I mean that making sure that we run that through the different programs that are available to us online. There are programs that you can run your writing or your messaging through that tells you what grade level is that on, what reading level it's on. We know that most newspapers are at the 6th grade reading level, but most of the things that we put out, we were finding were at the undergraduate level, as far as things that the science community or the public health community was putting out. So we need to be more mindful of that. Yes, it takes more work and it takes more time and it takes some unlearning, to be frank. Take some unlearning of the things we learn. We all like to kind of show our education and show what we know, but that is actually a hindrance. And so just remembering who we're trying to reach and being more clear about what exactly we want the public to do with the information that we give them. We have to make sure that we are tailoring our message for the different groups that we are trying to reach as well.
I think in terms of solutions for towns, cities, the countries, it all kind of applies, that every once in a while, it's not unheard of for us to be called into a community where mis and disinformation are being blamed for a host of problems, that vaccine uptake being one of them. But then when we do focus groups and surveys and key informant interviews, what often comes out are other issues, usually access or just questions and concerns that were never answered. So I think what scientists, what public health can do is really to double down on these tried and true practices we've used for a while, especially in HIV, these, community-based participatory approaches of both gathering information, but also co-creating a solution with the community members. But remove the paternalistic part of it and see that the community members can be and are as invested in their own health as we are. So, definitely more involvement with the community doesn't hurt anything.
In some ways, local leaders have advantages that federal leaders don't, right? They're more likely to know the people in the community. There's familiarity, greater trust, et cetera. That's not true for every community, but, that the kind of dialogue that we've all been talking about, the sort of civic science model, as it's sometimes referred to, that it's practiced at the local level. You can start with your elementary schools. There's a lot that local officials can do, even when we're not in a crisis. And in fact, that's when, that's as important as reacting well in a crisis, is to, continue to maintain that familiarity with science and research and public health officials.
Trust doesn't occur overnight. It develops over time. And those of us at the national level, we can add our voice and reinforce the message. But the truth of the matter is that local official who's been to the bake sale and was at the PTA meeting and was there when their family member got sick, who brought a pie by the house, particularly in smaller communities, who see them at the community fair, that person's trust over time is going to be much more impactful. I can add it on with my message, but the other thing is my message has to be in sync with that local person's message. That only happens if we don't exchange business cards in the middle of a disaster. That only happens when you engage communities progressively over a long period of time in productive ways, and as you've heard from the others, in a non-paternalistic manner.
Okay, so I'm also just wondering, that's the part that you deal with, but on the other end, within medicine and science, what should the scientists and doctors and medical professionals be doing to combat this distrust?
Yeah. So that's twofold. So I'll talk about the science or sort of research community and then the medical or clinical community. As far as researchers and scientists and the people who are pulling together the data and then putting it out publicly for community reception, I think we need to really mind the language that we use. Now, plain language is a concept that is not by any means new. However, it seems to be one for us recovering academics and current academics. It's hardest for us to incorporate. We know that there has been a long-term breakdown in science education in our public education system. And so it's can't be assumed that when we put out words like immunocompromise, for example, or herd immunity, we can't take for granted that the public understands what that means. And sometimes instead of saying, hey, I don't understand what that means, can you say more about that? People just sort of shut down and look elsewhere for more digestible forms of information. So we really have to be careful and make sure that we're not talking to just each other when we put out any type of science or research, particularly that is of importance to community health. And for the medical and healthcare industry, it would be helpful to just remember these concepts of dignity and being mindful and watchful for any sort of bias. So the medical care starts from the moment someone steps foot into that hospital. At the door, what types of questions are they asked? What kind of reception are they receiving? If they receive a negative reception, someone maybe asks them a question that seems to be stigmatizing. For example, are you on drugs? Have you used drugs? Or something like that. That can immediately cause that person to go into a state of, okay, this is affirming what I already believe about these institutions. I'm going to receive a negative experience here, even when it comes to my body and the actual health care that I receive. So we really stress with our medical and clinical partners, let's be hyper vigilant for the reception that people receive, the questions we ask them, the dignity that they feel when they step into the door. That is really going to be critical to improving our relationships and the trust that we have with folks in these communities.
Is there any way that organizations like those that you guys work for can work together with psychologists on solutions?
Well, we're partnering together to actually do exactly that. We're talking frequently. We're engaging one another. We're collaborating on projects, on webinars, on events like this to do a better job of educating the public. And then, to the extent that we can leverage each other's strengths, particularly each of us who have local affiliates or organizations that are in communities, we can partner to do that. We can also advocate for both the federal, state, local leaders to do the right thing, to make sure that the information that's put out by their official sources are factual, that people are using trusted messengers throughout the system, and that when they see another colleague appear, whether it's a politician or health provider or a business leader, putting out misinformation, to rapidly correct that information. In many ways, as they say, speak truth to power.
Is there any on the ground contact that's been made with people that's filtering back up with solutions that originate with people on the ground? Are you hearing any of that? Perhaps through community leaders?
Yeah. Blacks Against COVID, which is an organization, was started by a bunch of folks during the COVID pandemic, have been doing a lot of that. Groups like the National Action Network, absolutely. NAACP, absolutely. Those groups all have strong community-based organizations. The Urban League, another organization that's in communities, trying to make a difference. So I think that that's from a civic science perspective, those are groups that are involved. And of course, CDC is a strong partner, part of the federal, state, local governmental partnership, and then partner with us non-governmental organizations. Each and every day are in the communities. They provide resources, they provide expertise and technical guidance to help us all do a better job of engaging community.
Yeah, and I'll add into that CDC continues to partner with the American Psychological Association. We funded different research streams related to mis and disinformation and building vaccine confidence. We work a lot with the American Psychological Society as well, APHA, but also, we have a number of different teams at CDC that support our state and local jurisdiction partners, who we often get great ideas back from them on how to engage the community, how to leverage their voices and their thoughts to really address this issue. So it continues to be a priority for CDC to partner with everybody that we can.
Jenny, did you want to add any solutions that we haven't mentioned already?
I can speak to a number of grassroots activities that our alliance members did. For example, the Gladstone Institute in San Francisco did a series of, ask us about COVID, and had people from all over the area just call in. And this went on for weeks. It was very, very popular. We have a group of med students at the University of Pittsburgh who started a group called the Influencers and have been working at the community level. So we've seen a lot of activity among our organizations, and joining with the CDC, with APHA, and with other organizations, and then just coming up with ideas and going out there and executing them as well.
Dr. Van der Linden?
Yeah, maybe I'll just say, based on some research we've done, both input we've gotten from people and organizations that have concerns, but also talking to journalists and medical professionals. We talked a lot about risk communication and trust and how to improve that. There's a philosopher named Honora O'Neill who has a really interesting kind of critique of the typical way in which we measure trust, which is through, polls. And she sort of asked, but what are you asking people? Do they have trust in this? Do they have trust in that? It doesn't really mean anything. The real question is, would you ask people, who do you trust to do what exactly? And she's sort of talking about, interactions in our daily lives. Who do we trust to do what, for what kind of service, what kind of task? And those answers may be very different from whether we trust scientists or doctors in general. And it kind of boils down to this question of increasing trust can only really occur by demonstrating trustworthy behavior. And so the question is, what is trustworthy behavior? And we've developed some guidelines for risk communication that we think might be helpful for practitioners to demonstrate what people seem to perceive as trustworthy behavior, which includes talking about risks and benefits, which doctors always, and at least should often do. But it's also about being open, about uncertainty, being transparent, talking about the quality of underlying evidence, admitting concerns and talking through concerns that people might have, helping them to identify misinformation without necessarily attributing any sort of blame, portraying weight of evidence, and offering balance. I mean, not false balance, but there's always several perspectives that you can bring to a particular issue. And in all of our testing, what we found is that the people who are most hesitant and show the most sort of negative reactions to content about vaccinations are more interested in reading about communications that meet these guidelines than the type of communication that is meant to be highly persuasive and sell people on a particular course of behavior change. And so I think that's an interesting finding, that actually just demonstrating trustworthy behavior by informing people to the best of our ability and empowering them without forcing a particular decision on them seems to be useful for gaining trust. And so that would be my 2 cents.
And with that, I want to thank everybody for joining this panel today. On behalf of the American Psychological Association, thank you for joining us today. We hope that we've offered some actionable strategies for curbing misinformation and disinformation and building back trust. For more information on this issue, please visit apa.org.